Okay, well, it looks like we have a few that have come on in. So we'll go ahead and get started. My name is Monica Hartung. I welcome you on behalf of the Community Relations Committee as part of the Schneck Foundation. We're delighted to have you join us tonight on this joint pain seminar tonight. Hopefully you had a chance to view the video that was previously sent out and you're ready to get your questions answered. Just a few housekeeping details for our session tonight. This is being recorded, so it will be available for viewing on Schneck's YouTube page later this week. We will introduce all of our panelists here, and you can start asking your questions. Just be sure to use the Q&A button kind of at the bottom of your screen there. You can choose to submit your questions anonymously if you want to, and then I will ask those questions as they roll in, and we'll answer as many as we have time for. So feel free to get those out to us. So what we'll do now is let each of our physicians introduce themselves, tell you a little bit about themselves and what they like about orthopedics. And we'll start with Dr. Girth.
Yes, my name is Dr. Paul Kevin Girth. Paul, you'll see on official notifications, I go by my middle name, Kevin. Unfortunately, I'm the senior member of this group, at least in terms of the longevity of my career. I've been doing this for about 33 and a half years. The first 28 of which were in Michigan. And then the last 5.5 years, I have been here at Schneck in Seymour. I really enjoy orthopedics for multiple reasons. The breadth of the practice that I have, the variety that offers me keeps it very interesting and stimulating. I think what I like the most, though, is seeing my patients improve functionally. I think that by and large, that's what our profession embodies, is having patients who have a dysfunctional extremity or something that they can't do because of pain or stiffness. And our interventions very often can assist them to lead the lifestyle that they really, really want. And so that's very gratifying to be a part of that process.
Wonderful. Thank you. Dr. Michaels, you can go next.
Okay, I'm Jill Michaels. I've been at Schneck for 9.5 years now. I have to echo a lot of what Kevin said, in that orthopedics has been really satisfying in that you can almost, maybe not instant gratification, but very quickly see dramatic improvements, not seeing chronic ailments all the time. What drew me to orthopedics is I was very interested in sports all my life and had a few orthopedic injuries of my own along the way. And I just knew I didn't want a desk job. So I wanted to do something to help people and help athletes. And I thought that was a pretty cool job. So here I am.
Very good. Dr. Marr.
Hi, I'm Dr. Darcy Marr. I come to you by way of Canada. I was born and raised in Canada. I did my medical school and residency in Canada. I subsequently did a fellowship at UIC in Chicago. Been in practice for about 3 years now, 1.5 years here at Schneck. My focus is on general orthopedics, including joint replacement and minimally invasive surgery of the shoulder and knee. And, you know, I have to agree with Dr. Girth and Dr. Michaels. I was really drawn to orthopedics because there seems to be a clear-cut problem to solve and injury to fix. And I really enjoy getting patients back to the activities they enjoy.
Wonderful. And Dr. Williams.
Chris Williams. I've been in Seymour practicing orthopedics for going on 14 years now. So kind of been around here the longest, I guess, out of the group. My practice consists a lot of joint replacements, but I am a general orthopedic surgeon. I do everything from little kids' broken bones to carpal tunnels and everything in between. I kind of echo what my partners mentioned, that you know, I love fixing people, and I love getting them back to the activities they enjoy, and seeing that enjoyment with my patients when they're able to get back and kind of get back to their activities. And that brings me a lot of joy on pretty much a daily basis. So I love my job, and I can't imagine doing anything else.
Awesome. Okay. Well, so now that we've kind of met everybody, what we'll do is just kind of get going with some questions. So those of you who have joined us, feel free to send us any of your questions that you might have for any of our physicians. And as those come in, I'll definitely push those out to our panelists. But let's just go ahead and get started. Let's see here. How do I know if joint replacement is for me?
Well, that's an important question, because at the end of the day, that question has to be answered before proceeding any further. And there's multiple ways to answer that question, and it can be complex, but essentially one criteria is that you have failed non-surgical or conservative treatment, because there are several things that can be done, particularly in the early to moderate stages of arthritis, that could be helpful and allow an individual to at least delay or put off what may still be the inevitable. So I think failure of conservative treatment is one criteria that we look at before deciding if an artificial knee is for a given patient. And then there are other factors, some of which are in their control, some of which are not, such as their general health, body weight, what their expectations are, that also have to be factored in.
Very good. Anybody else have anything on that?
So I'd just like to add to that, you know, when a patient does have joint pain, I'll just expand a little bit on what the non-surgical treatments could be. So it could start from anything as simple as activity modification to diet changes and weight loss. We could move on to simple things like over-the-counter Tylenol arthritis, or some prescription anti-inflammatories if they're indicated. Failing that, we could include physical therapy and home exercise programs. And failing that, we can move on to types of injections like steroid injections or gel injections, just to expand upon what Dr. Girth was saying with conservative measures for joint arthritis.
Very good. Anybody else? Dr. Williams?
I think it's, they kind of covered everything there.
Okay, very good. Let's see here. My next question was going to be, what can I do besides surgery? But you guys kind of already covered that in there. One of the questions that we have here is, what makes a good candidate for the Mako surgery over traditional? So I think people are very curious about that.
Yeah, I'll take that one. So with the Mako surgery, in my opinion, anyone that's a candidate for a joint replacement would be a candidate for the Mako robotic assisted joint replacement. The operation is very similar. It's just the technique and the instruments that we use that are different. So I think everyone that meets the criteria for joint replacement would be a candidate for the Mako.
Okay. Anybody else have anything to add on that? One of the follow-up questions to that is, what is the length of stay for Mako versus traditional? Does that differ?
I guess I'll take that one too. So as far as the length of the stay, I don't think that that really changes depending on whether you have robotic assisted surgery or what we were doing prior to this, which is more of a custom cutting block surgery. But compared to a traditional knee replacement where you're using the intermedullary guides where you put the rods inside the bones, I think that has a tendency to increase someone's length of stay in the hospital compared to a extramedullary technique like using the Mako. So from that standpoint, I think it can decrease the length of stay. But really the main, I guess, advantage to the Mako is that you get a more accurate component position and a more accurate balance to the joint when everything's done. And that, as we've seen in literature and studies, will oftentimes lead to a longer lasting implant. And so in my mind, that's the real benefit to the Mako.
Okay, great. Anybody else have anything on that? we've got some questions rolling in. I have had a hip replacement 2 years ago. I'm still having trouble with one area in my upper leg. Seems muscular, but I'm not sure. I have joined an exercise place and have been in a month plus everyday activity, but I'm not any better. Do you have any suggestions?
I'll tackle that. The thigh pain after hip replacement surgery is not common, but it can happen. I think categorically, the two most common reasons for that may be directly related to the procedure is a type of tendonitis in front of the hip joint that stems from irritation of the tendon on one or more of the metallic components that generally either resolves on its own or can be resolved with conservative treatment up to and including corticosteroid injection at the appropriate location. The other fairly common cause that again usually resolves in a few months at least is pain in the mid-thigh at the tip of the femoral stem. And so when we insert a femoral stem into the femur, that is a stiff piece of titanium, which is relatively speaking more rigid than the bone into which we're inserting it. And so that mismatch of stiffness, which we call modulus of elasticity, can be a source of thigh pain. It generally does resolve within the first 12 months. And so if it's been 2 years, as in this caller, that would be less likely, but there are certainly diagnostic tools that we have at our disposal to try to figure those things out. So those are the two issues that can cause thigh pain directly related to the hip replacement. And of course, there are multiple things that have nothing to do with hip replacement surgery that can cause thigh pain that also need to be investigated. But I wouldn't give up on that. If that's for that particular individual, if it's a very significant degree of pain that limits their activities, they should see their operative surgeon and try to really pin down the diagnosis and see what can be done about it.
Very good. Thank you, Dr. Girth. I have another question that's come in. Is it common to have joint pain during colder months, and at what point should a consultation be done?
Yes, I'll speak up. I think yes, I feel like we see a lot of patients that have more joint pain during colder months. I don't know if we really know why per se. I think it may have something to do with barometric pressure and things like that. But I think anytime, if pain's limiting your activities of daily living or interfering with sleep or interfering with any activities that you enjoy doing, then I think that's time to get it looked at a little bit further, more extensively. And that's where we would be happy to help.
Very good. Anybody else have anything to add to that?
I think anecdotally, my patients often comment on that their joints, whether it be joint replacement or arthritic joints, seem to hurt more in the cold months. I don't know of any really good studies about that, but it seems to be something that people commonly will comment on.
Okay. Sorry, we have a follow-up to the other question, but we can finish this one first. Anybody else about the cold weather months? Definitely that seems like something people comment on. They can tell that the weather's going to change and these kinds of things.
So just the back end of that comment of when a consultation is recommended. So if anything is hurting you for 6 weeks or longer, in my opinion, it deserves an x-ray. So you should come on in and see us. We can do that for you and work up what's causing that pain for you.
Very good. Had a little follow-up on the thigh pain question. Part 2 of the question, it only happens when I lift my leg to get in the car and getting dressed. Sorry, I'm the one with the hip replacement 2 years ago in March, just clarifying.
Yeah, I think that sounds like what Dr. Girth was mentioning with the psoas tendon irritation. That sounds like, to me, that's probably what it is.
Okay.
Could be, anyway.
So perhaps worth getting in to see her doctor.
Absolutely. I would agree. That sounds like, tendonitis, either the iliopsoas tendon or the rectus femoris tendon, which means nothing to the patient. Just know that those are potentially treatable conditions and not something necessarily that patient has to endure.
Okay, something they can be have that looked into. What would be some potential complications with surgery if I were to go through with a joint replacement?
I'll take that. I've been doing it so long, I've seen every complication known to man. The most common complication is probably residual pain, just like the caller mentioned, who's had pain for 2 years. And most of those things do resolve over time, or they are treatable with additional non-surgical methods. Not so much with hip replacement. Hip replacement is one of the most predictable operations that we do. And good, excellent results are seen in well over 90% of patients. Artificial knee replacement, by its nature, tends to be a little bit less predictable in terms of absolute pain relief. And so again, the most common complication of knee replacement would be some form of residual pain, weakness, or instability. There are other complications, all of which are well less than 2%, things like infection, leg length inequality, neurological injury, blood clots. All of these have things that, or all of these include measures for which we use to prevent them. And I would put Schneck Hospital at the top of the list in terms of how well we do in terms of minimizing complications, but none of them are zero. But there are things that we recommend and that we do to try to minimize those complications. So there are several potential complications, most of which are in the 0.5 to 2% range. But overall, it is a very successful operation for most people.
Great. Anybody else have anything to add to that?
Yeah, I think you covered it.
Okay, very good. Does everybody have to go through medical clearance in order to proceed with surgery?
I think it depends on what kind of surgery it is. For the most part, as a hospital, our policy is to perform some kind of review of a person's medical history, even with the smallest surgeries. And that can be something as simple as a phone call. When it gets to something more complex like joint replacement, it is the recommendation to have medical clearance done. And that basically identifies and eliminates potential complications before they happen. We really leaned in hard to that process back when I started in 2009, and we saw our complication rates dramatically drop. Things like blood transfusion and even medication reactions and things like that. It's kind of become a thing of the past after implementing our medical clearance process. So it's a very important part of your surgery and your recovery afterwards.
When I decided to relocate my practice in 2018 to Seymour, I had multiple options and went to various hospitals and had several interviews. One of the main reasons that I selected this hospital was on the strength of their hospitalist program, which is what we're talking about now. So we have some outstanding hospitalists that participate in this so-called PACE program or preoperative clearance program. They do an outstanding job, not just a preoperative assessment to mitigate risks, as Dr. Williams suggests, but they also assist us postoperatively if there are needs or complications that arise. But it was, of all the hospitals that I interviewed back in 2017, I think this hospital stood out as the best in terms of their preoperative hospitalist preparation program.
It's great information. Anybody else have anything? No. So then the follow-up to that was, does everyone have to go through that? And it sounds like yes.
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 Okay. And here's a question. Can both knees and hips be done at the same time?
I feel like,
yeah,
I feel like Dr. Gerther or Dr. Williams should do that because they're probably the only ones that actually do that. I won't do either. I won't do bilateral knees and hips at the same time. That's a no for me.
Yeah, I think if you look through the literature, there are increased risk of complications if you perform bilateral joint replacements. you know, things like blood clots and even infection. I think there are some certain circumstances where it might be appropriate if a patient has a really bad deformity bilaterally, and that would be something like if they couldn't fully extend their leg, or they had a really bad flexion of their leg that they couldn't correct. If it affected both sides, sometimes it's better for a patient's recovery if you go ahead and do both, and then it just makes the recovery process easier. Rheumatoid arthritis patients sometimes fall into that category, but for the most part, I think in the since 2009, since I've been here, I performed a bilateral knee replacement one time, and that was for a severe flexion contracture in a rheumatoid arthritis patient.
Very good. Dr. Guth, did you have something to add to that?
I have historically done several bilateral total knee replacements, and for the most part, I've been pleased with the results. But I echo what both Chris and Jill have said. First and foremost, I am very selective. So the two criteria that I demand really before considering bilateral total knee arthroplasty at the same time is, number one, very significant arthritis with deformity, such that if you only do one knee, you're not going to be able to adequately rehabilitate because your other knee, it just doesn't have the range of motion or the ability to bear weight to permit that. And then secondly, the comorbidities or the health of the patient. So the patient has to be relatively healthy. So if they meet those two criteria, I think it's reasonable. Beyond that, the data is clear that the risks are higher. As far as hip replacement, I don't know if anybody is doing them simultaneously. I've never done that. There is some literature supporting maybe separating two hips by a week or so. I don't know if Chris has experience with that. I've done that once and things went fine, but not simultaneously.
In training, I've done bilateral hip replacements many times, but again, I don't think that's necessarily supported by the literature. But I will do them as close together as the patient is comfortable with. You know, if they come to me at 2 weeks post-op and they want to go ahead and get the ball rolling on the other one, I've done them fairly close together. I would say the average time span between two total joints, at least in my practice, is probably 3 months is kind of the average when the patient is ready to go ahead and have the second one done.
Okay, great. Kind of following with that, after we've had a replacement, what does the rehabilitation process look like for most patients?
Did you say for hip or knee or both?
I think you can choose whatever you want to talk about.
Okay. Yeah. I think for our hip replacements, I mean, at least Chris and I are doing the anterior approach. I think that has proven to kind of help speed up recovery. And so their weight bearing is tolerated right away. Usually, I do start on a walker, but there's really not, I don't put any restrictions on them as far as, crossing the legs or bending over. Most of the time pain will kind of limit that itself. And then as far as knee replacement, again, still walking on it the same day and immediately, and as weight bearing as tolerated. Again, usually needing a walker at first and then graduating to a cane. But physical therapy is very important in both, probably especially the knee, trying to regain the range of motion. I think we can all put a good knee in, but it really does take the patient's commitment to do the physical therapy to get the range of motion back, especially in total knee replacement. Especially the hips are a little bit easier on that, but the knee is definitely. I feel like therapy is very important.
Very good. And how long does that recovery process tend to take for most patients? To getting them back to, where they're getting rid of that walker and these types of things?
Yeah, that's a very common question. Virtually every patient asks that question.
Right.
And it's probably the most difficult question to answer because you don't really know what context that they're asking the question about. So I begin by saying they're in the hospital for 1 to 2 days. They're using a walker for anywhere from 2 to 4 weeks. Physical therapy will, again, be a range of, say, 4 to 8 weeks. Most people are driving within about 4 weeks. That seems to be an important landmark for most people. And so they want to hear that. But for the patient who asks that question in the context, well, when will I be completely recovered? When will all of my pain go away? When will it not swell after I walk 2 miles? That can be a full year or even 18 months. So most of the recovery does occur in the first 6 to 12 weeks, but there's certainly a leveling off of that improvement that lasts for several months after surgery.
Very good. Anybody else?
Yeah, I agree with that. I would say, well, I mean, to get a little background, so for people that meet the criteria, I'm sending people home the same day of surgery after total joint replacement. And by the time they leave the hospital, they're able to do a couple of stairs and walk with a walker. And then they go home. They do, like Kevin said, between 4 and 6 or 4 and 8 weeks of physical therapy. But usually about 6 weeks, people are feeling like, okay, this is something that's going to work for me. And by about 3 months, they aren't really too concerned with it. And that's kind of on average. But I think the literature would also support that the overall recovery time after joint replacement is really about 2 years is when you finally see a full plateau of recovery. Now, like I said, most people are doing really good at 3 months, but they will continue to see small improvements in, swelling and occasional pains and maybe range of motion for up to 2 years.
Great. So another question is, will somebody need to stay with me after surgery? And if so, for how long?
I guess it depends on what kind of surgery we're talking about, but if it's on the knee or a joint replacement side of things, I think it is a good idea for someone to have somebody stay with them for at least a few days to make sure that you can get around your house and kind of navigate things in a safe manner. I just think that's a good idea. So if that's not possible, sometimes we will set people up with a short-term rehab stint where they can stay in-house in a rehab facility for a week or two, just until they're kind of comfortable navigating their home. But certainly having someone at home to help, it makes that process a lot easier.
If they go to a rehab facility, they're required to stay in the hospital for a certain length of time to be able to qualify for that?
Yeah, and that just depends on their insurance. Sometimes it's up to 3 days, sometimes it's less. It seems since COVID, things are kind of in flux with that. It seems they used to be pretty strict on the 3-day rule, but since COVID, that's kind of all over the place. So sometimes they get them in the next day, sometimes it's 3 days. Just kind of depends on the insurance.
Okay. And actually, since you mentioned insurance, another question we have is, does insurance cover joint replacement surgery?
Yeah, it does.
That's the short answer.
It better. Yeah.
Right. That's the best spot. Do I need to lose weight before surgery? I think that's certainly something people wonder about. And we hear about having to have a BMI in a certain range before surgery.
So I can take that one. In general, for the lower extremity replacements, the recommendation is to have a BMI under 40 to decrease your risk of complications, such as wound healing problems or even potentially wearing out the implant quicker than anticipated. So it'd be a case-by-case basis to figure out if you did need to lose weight before surgery.
Anybody else have any follow-up on that? We had some other questions coming in, so we'll ask those. Can having a tibial plateau fracture in 2018 affect your ability to follow through with your steps? I never had surgery for the break. I took 12 weeks of rehab, Never really helped with that particular thing. I have discussed this with my surgeon, but we haven't found a direct answer. The time of injury, I also tore my labrum, but that was fixed a couple years ago. Would like to get back to how I was before the fall. Hopefully this makes sense. So I think the question is like the ability to follow through with your steps. So that's the question. Affect your ability to follow through with your steps.
So I may be interpreting this incorrectly, and correct me if I'm wrong, but at the time of the tibial plateau fracture, there may have been some other injury, such as an ACL or ligamentous injury in the knee. That's possible. That can make you do what's called a short step or not fully extend your knee as you're following through with your step. I think that's what the patient may be asking. So it may be worthwhile to get some imaging of that knee to determine if there's another injury.
To look into that a little bit more.
Yeah.
Another question we have is, how long does a joint replacement typically last? Do you see that people having to have the same joint replaced more than once, or is this going to be a lifelong thing with once?
I think we see joint replacements lasting, I think, literature supports 10 to 15 years on a knee, maybe 15 to 20 on a hip. But I do think that I think it's the matter of how they're put in. If they're put in well, they'll last a long time. And that's where I think the Mako is an advantage, because it does allow you to put that knee in and that hip in and the correct alignment to make it the longevity last. I mean, definitely in my practice, I always encourage people to wait as long as they possibly can, because definitely the older they are when they do get the joint replacement, the likely that is to last their lifetime. And that's definitely my goal, is for that one joint to last their lifetime. But as we're more active and more younger patients are getting more arthritic joints, there are times where 45-year-olds are getting total knee replacements. And I think you just have to have that conversation with them that, you being younger too, you're more active on that total joint replacement. So I think that also can contribute to it wearing out, or, on the longevity of that knee. So that's where you just have to have that conversation with that patient, and just let them understand that there is a possibility of needing a revision knee replacement in the future, the younger you are.
Okay. Very good. Anybody have anything to add on that?
Yeah, I mean, that's a very common question that patients ask, how long the implant will last. And it's really dependent on a lot of different factors. One thing you can think about is the actual materials and how long are the materials going to last. And these things are tested in a lab. They cycle them and they replicate, decades of use on these materials. And they're 40, 50 years of wear life in some of these replacement parts. But that doesn't take in consideration, real world activities of patients. And it really depends on, how much abuse a patient is going to put this joint replacement through, as well as, like Jill said, how accurately the components are placed. In the lab, when they're cycling them for decades, that's perfect placement. And we try to get there. And I think as the years go on, technology allows us to get closer and closer to that ideal placement. So I think, that's kind of a shifting answer. As technology improves, materials improves, these implants will last longer and longer. The implants that they're studying that lasted 15 years, those implants were put in 15 years ago. So you just kind of have to keep that in mind. But I do, that's what the literature would support, is the 15 to 20 year thing. But I do see the potential for them to last much longer in more ideal conditions.
I apologize. I've got a little bit of a tickle in my throat. I think we had another question come in here. Dr. Williams did a great job on my knee replacement. However, I have pain around my ankle on that same leg as my knee replacement. Is there something I can do to help the pain and slight swelling around my ankle?
I'll take that question.
Yeah, go ahead.
Just to keep Chris off the hot seat since it's patient. Many times, I don't know the specifics of this individual, but many times a patient will come with a malaligned knee. So in other words, their knee is not straight because of the wear of the arthritis, preferentially on one side of the knee. And that, of course, is something that occurs very gradually over time. And in that individual, that patient, the ankle and foot is used to hitting the floor, if you will, at a certain angle. When we do knee replacement surgery, we try to realign that knee to what we consider to be what it should be, so-called anatomic alignment, which may be several degrees different than what it was before. So now, suddenly, that patient's ankle and foot is striking the floor at a different angle. So that could be a source of that pain. And generally speaking, when that happens, it's a matter of time before the ankle and foot adjust to that new position. Sometimes chronic swelling can occur after a knee replacement for a variety of reasons. And much of that swelling can collect in the area of the ankle and foot and can be a source of at least some achiness. And any measures that we utilize to decrease swelling can help that condition. If it's already been several months to 2 years since the knee replacement surgery and the ankle pain is still there, then you have to consider that the ankle pain is not related to the knee replacement at all, and that there's something intrinsically wrong with the ankle, and that would merit an independent evaluation of that joint in and of itself.
Very good. Anybody else on that? All right. This is just kind of a fun / silly question. Which surgeon is the best?
Did this question come from a patient or a participant or one of the surgeons?
I believe it's been planted.
Oh, it's planted. Okay. Yeah, last time too. Kevin immediately no, it was Jill chimed in immediately that it was her. So last time.
Only female in the group. You gotta put up with these guys. So that's why I get the best.
I think I would have any one of you. So just as far as the questions we've been through, I thought we talked about all the pieces of this. So when a patient comes for like their initial consultation, kind of just walk me through what that's going to look like. So you'll consult with them, you'll go through some conservative measures. So how long from when they initially consult to when they may eventually have a joint replacement surgery? How long does that look like?
I can try to tackle that one. That's highly variable.
It is, but it'll just give us something to kind of walk through a little bit.
So, it depends on the degree of the arthritis and also the degree of symptoms and disability from that arthritis in the joint. If somebody's not tried anything and wants to go through or needs to go through all of the conservative measures, it may be, on the order of months to years. If somebody's tried or gone through the conservative measures elsewhere, it may be, as soon as the initial consult, depending on the severity of the disease and what's been tried in the past. So it's highly variable, and it would all depend on where you are on that cycle of treatment.
Okay. Does insurance require you have injections or physical therapy or anything like that before you can proceed to a joint replacement?
Yes. So you'd have to prove failure of all conservative measures before proceeding.
Okay. So yeah, depending on where they are, then where they come in at on the process, it may be sooner than later, or maybe quite some time.
Correct.
Very good.
And just to follow up on that, I think when a patient asks me how long will it take to actually be in the operating room, and this is at the moment that we're making the decision that yes, it's time to schedule your surgery, that's a common question. My answer is approximately 7 weeks, which includes 3 weeks for the preoperative assessment program that we spoke about earlier, And then depending on our respective schedules, I'm booked out about 4 weeks. We don't really actually schedule the surgery until they've completed the preoperative assessment. Again, that takes about 3 weeks. And once we've got notice that that's been cleared, they go on my schedule, and that's about a 4-week lead time. So that's where the 7 weeks comes from. And I think all of us are, kind of in that same time frame.
Very good. Anybody else on any of that? Had a question come in about gel injections, varying degrees of success on those. Can somebody talk about that? And then the follow-up question to that was, are gel injections used for ankles?
So as far as I know, I don't think gel injections are approved for ankles. And I think that they're only approved for knees, as far as I'm aware. What was the first part of the question, I guess, what they're...
just how successful are they?
How successful? I would say 50-50 is what I usually tell patients, because I do have some patients that really do great with them. And even, they last a year, maybe I've had some 2-3 years, which, and I think it also depends on the amount of arthritis that's in that joint. More advanced arthritis, probably they don't see as good of results with them. Whereas if it's more on the moderate or mild end, I think they do get good results with them. So I guess it's probably going to be a conversation after the surgeon, or clinician senior x-rays to give you a little bit better prognosis on if they're going to work or not.
Okay, very good. Anybody else want to chime in on the gel injections? So we have a number of surgeons here. The question is, who specializes in what joints? So if you want to talk about your particular either area of interest or specialty, or subspecialty within the group.
I can start. Like I said, the majority of my practice is knee and hip replacement. But being a general orthopedic surgeon, I also do sports type surgeries, knee scopes, shoulder scopes, rotator cuff repairs. I also do trauma work, fractures, and things like that, as well as some hand carpal tunnel. But the majority of my practice is hip and knee replacement.
Okay, very good.
My response to that question is that early in my career, in fact, for 28 full years, I had a practice similar to Chris, a large volume of total knee and hip replacement. Here, I sort of filled a void in doing some upper extremity types of procedures that weren't otherwise being done here. So I've sort of morphed into the upper extremity surgeon, including shoulder replacement surgery. Like Chris and like the rest of us, we all have a wide variety of procedures that we do. And I enjoy all of them, but I have sort of navigated or trended toward upper extremity surgery.
Very good.
Yeah. So again, yeah, we're all pretty general. I think we all do a little bit of everything, but I guess I would say my niche is more shoulders. I do do both anatomic and reverse shoulder replacements. Also very, more complicated rotator cuff tears. And I did a fellowship in sports, so a lot of sports injuries. But I do total hips and total knees, although total hips are not my favorite. So I'll gladly defer to the others for those.
Very good. Dr. Marr?
All right. So my practice, like the others have said, is a general practice as well. I did a sports fellowship as well, so specializing in shoulder and knee surgery, both replacements and minimally invasive surgery for both of those joints. But just like the others, trauma and general orthopedics as well.
Very good. Another question that came in: what causes arthritis and how can I prevent it from occurring?
The vast majority of arthritis is osteoarthritis, otherwise known as degenerative arthritis. It is a function of aging primarily. It can be a consequence or a sequela of a previous injury, in which case it would be called post-traumatic osteoarthritis, but it has the same overall clinical appearance. There is a hereditary component. So Americans of Northern European descent generally are a little more likely to develop arthritis, but it certainly affects all demographic groups across the spectrum. All of us, if we live long enough, will have some degree of osteoarthritis. There are also other categories of much less common forms of arthritis, such as rheumatism, which falls in the category of inflammatory arthritis. That definitely has a hereditary predisposition and is largely unavoidable. Inflammatory arthritis, which again is the minority of the types that we see, is sometimes very modifiable with aggressive treatment and often is best done under the care of a rheumatologist. As far as osteoarthritis and things that patients can do to at least slow it down would include regular exercise that is more low impact than high impact, but nonetheless, regular aerobic exercise. Flexibility exercises are helpful, and of course, weight loss. There's also some evidence that smoking contributes to the development of osteoarthritis, and smoking cessation is also, I think, a key factor. So to summarize, don't smoke, try not to be heavy, and if you are, try to lose weight and stay in shape. And other than that, there's not much you can do. You will eventually all become one of our patients.
A couple more questions that came in. If you have a series of gel injections and it didn't help, can you try another? The knee is specifically for this patient.
Yes, I think.
Oh, go ahead, Jill.
No, sorry. Yeah, I think you definitely could try again. Insurance will only cover those injections twice a year, so it has to be at least 6 months or more. But otherwise, I don't see why we couldn't try again.
Okay. Those cleared out of there. And then somebody else is asking about cortisone injections. So being different than those gel injections, when would you do a cortisone injection? How often can you do those?
I think the kind of the standard on a cortisone injection is you can have one every 3 months, whereas the gel are usually only covered every 6 months. Cortisone I'll often use for more severe arthritis, people that are trying to kind of kick the can down the road a little bit before they have their joint replaced. It'll help when the gel won't, but it just doesn't last quite as long. So that's kind of when I also use it as kind of a diagnostic tool as well. If unclear whether the patient is dealing with pain from arthritis or maybe some kind of ligamentous injury, I'll try a cortisone injection to see if it helps, and if it does, then a lot of times we're dealing with the arthritis, and if it doesn't, then more advanced imaging might be necessary. That's kind of how I use it in my practice.
Okay. Anybody else have anything on that?
Just a side note, it's interesting that the risk of infection from a cortisone injection or gel injections is actually very low. But interestingly, there are studies that show that if you do a joint replacement shortly after any form of injection therapy, that the risk of infection of the joint replacement is increased. So currently I advise my patients, if they've had either gel or steroid injections, that we must wait at least 3 months before considering knee replacement.
Okay, that's good information. We have 10 minutes left. So participants, if you guys have more questions, feel free to get those into us, because we will finish right at 8 o'clock, but we still have 10 minutes. And we do have a few more questions that have come in. I was a cheerleader for 13 years when I was younger and tumbling on hard floors. My joints, specifically my knees and ankles, often feel weak. What can I do to strengthen these joints or prevent further injury?
I mean, I guess physical therapy is where I'd start with. and just a regular, a weight or some kind of weight routine. Squats and lunges tend to be hard on knees and ankles. So trying to maybe avoid those or modifying those to where they're not causing more pain. But I think specifically paying attention to quads, hamstrings, but even like glutes and the core, I think are really important to lower leg stability.
Very good. And it kind of, another question kind of follows from something that was mentioned earlier. What types of exercise are bad for joints? Are you guys proponents of running per se, or prefer walking or swimming, or just if anybody's moving?
Yeah, I think in general, the lower the impact of an activity, the easier it is on the joint. Just recently, they came out again with a study on running, and that it doesn't seem to increase the progression of arthritis, at least in healthy knees. But just from my opinion, the lower the impact, the better. So I would rank, swimming is probably top of the list as far as low impact, and then something like biking and elliptical, walking on a kind of a springy treadmill, that kind of thing would be better than running on the road or asphalt on a daily basis. But again, I don't know that the literature necessarily supports that, at least in healthy knees. Now, in knees that already have a certain baseline of arthritis, I think that it's shown that the high impact activities like running on concrete will definitely progress that along a little bit quicker.
Okay.
I would simply add that one of the natural occurrences of an arthritic joint is progressive stiffness. There's a couple of reasons for that. One is the chronic swelling in what's called the synovial tissue, and the tissues just become less flexible overall. And then secondly, particularly with osteoarthritis, you develop bone spurs at the margin of the joint. We call those osteophytes. And those don't necessarily contribute to increased pain, but they can definitely contribute to stiffness. And stiffer joints tend to, the progression of arthritis with stiffer joints is more rapid. So I think in addition to the low impact exercises that we've been talking about, and Chris just mentioned, I think flexibility work is also an important part of any exercise program. At the very least, trying to not allow the affected joint to get stiffer, and in some cases, improving the range of motion of that joint, which can have a definite beneficial effect on the degree of pain and disability.
Okay, very good. And again, so that conversation about exercise, I'm trying to strengthen my leg. Is there anything to avoid at a gym if you've had a hip replacement?
I would say, and it really, some of it depends on how the hip replacement was put in, but I think in general terms, you want to avoid a deep kind of squat maneuver and twist at the same time. People usually run into trouble. If they're going to run into trouble, they run into it when they're bending and twisting at the same time. Instead of having the plane of motion all in one plane. If you're doing, let's say, a deep squat, and then you kind of twist your torso to one side, that might be where you'd run into trouble with a hip replacement.
Okay. I have a comment and a question, but the question seems like it kind of could be more involved. So I'm going to read you the comment first. Not a comment, not a question, but a comment. Thank you for taking your time from your evening to share your knowledge. You are all very good, and we appreciate what you do. So that was a very nice comment from one of our participants. What concerns in joint replacement are involved if the patient is diabetic?
So diabetes, definitely, there's some increased risk of infection. So we do take precautions to try to prevent that. We actually change or add an antibiotic, I guess, for both preoperative and postoperative antibiotics. Also want to make sure that the hemoglobin A1C is below 8 or less, tends to show that the risk of infection or complications is better.
Very good. Any other comments on the diabetic individual seeking joint replacement?
Well, during their brief hospitalization, the blood glucose is closely monitored and typically controlled with small doses of insulin in addition to whatever oral agents they may be using. We call that tight glycemic control. And fundamentally, I think that relatively tight glycemic control at home is still important, at least for the first few weeks after the surgery while the tissues are trying to heal. But Jill's comment about the hemoglobin A1C being less than 8 is really important. There's a lot of literature to support that. So that's, you know, one of the hard stops in terms of not doing surgery if someone comes to us and they simply don't have their diabetes under the control that they should have.
Okay, and so that would go back to being a piece of that preoperative clearance to get that under control before they would move forward? Yes,
and in some cases that can be an initial screen, and if the hemoglobin A1C is excessively high, they don't even get to the hospitalist to do the clearance. They're basically referred back to their primary care physician, who is helping them manage their diabetes and getting that under better control before even then going back into the PACE program.
Okay, very good.
That's how important that is.
Right. We're getting close on time. So how long does surgery take? So how long does a knee replacement take or a hip replacement take in the OR?
It roughly takes me an hour for a knee replacement and hour and a half for a hip, in that ballpark.
Okay. So
I'm a little slower, so it takes me a little longer, but still good results.
That's right. That's not a commentary on that. Another gal says, I have always heard only great feedback from patients who use Schneck Ortho. I am one of those patients as well. So another positive thought. And another gal says, just a comment, this has been very helpful for me tonight. Thank you for your time. We also have someone saying that they love the walk-in clinic. So high praise for all of that. Last question that looks like that has come in here is, what is a common treatment for carpal tunnel syndrome?
I can take that one. So there's again a spectrum of treatment depending on how severe your symptoms are and when you're having your symptoms. It can be as simple as splints that are worn at night that don't allow you to flex your wrist. It can include steroid medications or anti-inflammatory medications. In some cases, occupational therapy or an injection can be helpful. And if all those are failing, release of the carpal tunnel and opening up of that tight band that's squeezing down on the median nerve can be indicated.
Okay, very good. Well, I don't believe we have any more questions kind of in the holding pattern there. So I'm just going to wrap it up with a couple of comments here, and then we'll all be done. I want to thank everybody for attending tonight for our Schneck Orthopedics and Sports Medicine joint pain seminar here. I did want to let everybody know that we do have clinics located in 4 counties. The main office here at Schneck on the 5th floor, as well as offices at Schneck Family Care in Jennings County, Scott County, and Washington County. The office hours at the Schneck campus are Monday through Friday, 8 to 5, and walk-in hours are also offered for injuries Monday through Friday from 8:30 a.m. to 11:30 a.m. To make an appointment, you can, you can call 812-524-3311. And that information will also be mailed out following this webinar. And again, this was recorded, so if you have things that you want to go back and review, this will be up on YouTube within a few days. But again, we want to thank everybody for joining us. We want to thank our physician and physician panelists for taking their time tonight to join and share their knowledge and experience with our participants. So with that, thank you for joining us, and the foundation was happy to bring you this program.
Thank you.
Thanks.
Thank you.